Anthony Wright, Executive Director of Health Access, Emilio Varanini, the Deputy Attorney General, Dolores Yanagihara, how do I say it right?
Perfect.
Close enough. Vice President IHA, and Dr. Stephen Shortell, Professor at Berkeley. Thank you all for being here. I appreciate it. They're going to spend 5 minutes each on this topic, on data related to the topic of integration versus consolidation, and what we have learned in the last 10 years. And then we're going to have kind of an open discussion across the silos with the 4 or 5 of us, and we'll take your questions as well. So I want to move right through these slides. I don't want to spend too much time on them, but I want to give you all an opportunity to highlight some of the data that you have provided. So we got a clock up here.
Great.
You got 5 minutes.
Okay,
Dolores, take it off.
All right. Before jumping into the slides, I wanted to say a few words to provide context for the information that I'll be providing. And so the Integrated Healthcare Association is a healthcare leadership group, and we really play the role of convening stakeholders to come together and collaborate on solving industry pain points. One of the things that we've been working on for about almost 20 years now is really trying to bring data together and use data to do different kinds of performance measurement. We started out doing performance measurement of provider organizations in the managed care setting, and more recently, through funding from the California Healthcare Foundation, have been able to expand that to bring together data across all payer and product types. So we have basically a voluntary multi-payer claims database where we collect data from 12 health plans across commercial, Medicare, both managed care and fee-for-service. And then for Medi-Cal, we have results that are able to be provided in a comparable way to the other payer and product types. So just wanted to provide that context for you. One of the things that we have really been looking at in our data is trying to understand what are the things that really are associated with value. And when we think about value, we're talking about higher quality and lower cost. So we kind of bring together quality and cost in the concept of value. And so one of the things that we've looked at is trying to get around the concept of integration. The challenge is that there's not a very clear-cut, easily defined, and easily measured in administrative data definition of integration. So we've looked at HMO versus PPO with, kind of assuming that HMO will be more integrated and PPO will be less integrated, but that doesn't, with all of the different experimentation these days with models, that's not a super good definition. And where we've landed more recently is looking at one aspect of integration, which is financial risk sharing and the amount of financial risk that providers are taking. We're actually getting information at the member level, and so we're able to look at populations. So we look at members who are cared for by providers that take different levels of risk. So we're not measuring providers directly, but really looking at populations of patients that have similar characteristics. And what I'm going to share is characteristics about the providers that the members are seeing and the level of risk sharing that they're taking. So what we did is we bucketed the providers and the members into 3 different buckets. First one is those providers that do not take any risk, so they're paid fee-for-service. The second, and that's the blue bar, the second category is those members that see providers who take professional risk only. And that's so professional capitation. And then that's the orange bar. And then the third category is members who see providers that are taking risk for the full spectrum of care. So full risk, full capitation for both professional and facility services. And what we found when it comes to clinical quality is that those providers or members who are being seen by providers are getting the recommended care at a higher % of the time than those members who are seeing providers who are paid fee-for-service. So higher risk is associated, financial risk of providers is associated with better quality. So what do we see on the cost side of things? So this is a total cost of care, so average total cost of care per member per year. It is adjusted for the clinical risk of the population as well as for geography, because we know kind of the cost of doing business and pricing is different in different geographies. What we find here is that the providers, the population where they're seeing providers that are not taking risk are the highest cost, and the members who are seeing providers who are taking full risk are the lowest cost. And there's about a 3.5% difference in cost between the different groups. So when you bring that together, we look at the no-risk group has the lowest clinical quality, quite a large jump for professional risk, and then a little bit even higher even for full risk. That's on the clinical quality side, and on cost, you see the opposite. So the no-risk group has the highest cost, going down for professional and then down further for full risk. We looked at this geographically to see what happens, and so we're using the 19 covered California regions. So we're bucketing the members based on where they live and the type of risk that for the providers that they're seeing. And what we see here is that the no-risk group, they're almost all below the statewide average for quality. So the horizontal line is the clinical quality average for the state. The vertical line is the total cost of care average for the state across the whole commercial market. And what we see here is a wide range of cost, but almost all of them are below the average for clinical quality. When you look at the professional risk group, almost all of them are above the statewide average for clinical quality, but there are many of them that are in the higher cost quadrant. So not necessarily the best value, but still good quality. And then you look at the full risk regions, and those are almost all, again, above the statewide average for quality and spread out for cost, but many of them in that top right quadrant, which is the higher quality, lower cost quadrant, which would be the value quadrant. So you see there only the full risk and professional risk group are in that high quality, low cost quadrant. So what about ACOs? There's been a lot of experimentation recently about ACOs and trying to layer some integration on generally a fee-for-service model. And what we've actually found, which is different than we found 2 years ago, is that ACOs actually perform really well. They are about the same quality and about the same cost as the full risk group. So this was a really interesting finding to us. It's based on about 600,000 members who are a part of ACOs across the state. So that is what I have to say, and I'm not going to go through all of these. We'll click through. Oops, go back. There we go.
Thank you, Dolores. That's super interesting stuff that we could dwell in, I'm sure, for a long time. So I want to get back to it here in a little bit. But Steve, take it from there.
Sure. My comments are going to basically be based somewhat reinforce what Dolores has just shared with us. I wanted to find, though, a little bit at the beginning, this term integration. She's talked about risk, really. Emilio and perhaps others are going to talk about consolidation, economic, integration at the top with hospitals buying other hospitals or hospitals buying physician organizations, et cetera. I wanted to find the term for it so we have a level setting that many in the literature call really clinical integration, which is simply the extent to which the care that you and I get meets our needs and preferences across conditions, providers, and settings over time. And the major issue is to what extent does our increasingly consolidated healthcare system on the ground deliver the kind of value that Dolores and the rest of us will be talking about. So I'm going to share a little bit of information on that. Again, if we want to think about this, a way of affordability. This is about affordability over time. I have little doubt and a lot of confidence that here in our state, we're going to get to universal coverage. And Anthony and others may want to, elaborate on that. The question then becomes, how sustainable is that going to be over time? And in my own mind, and this is oversimplified, there are only 4 ways, 4 buckets to make things more affordable or lower costs while maintaining or enhancing quality. 1, deliver the care in lower cost settings. Stay out of hospitals. You don't need to do it in physician offices. Okay, do it at home, do it in the work setting. Okay. 2, use lower cost personnel. If you don't need a physician, the nurses can do a lot. Medical assistants can do a lot. Believe it or not, receptionists can do a lot. Community health workers can do a lot. 3, eliminate waste in the care delivery process. You know, I hate to admit it, but the thing you saw at the beginning at the conference or some point, our president, you know, said, geez, this is really complex. You know, yeah, we need to remove a lot of unwarranted complexity in the way in which we deliver care redesign. And finally, the best thing, of course, is stay out of the damn system to begin with, right? Stay healthy, meditate, eat good food, etc. And we need to give people more access to that. So with that as very quick background, right here we have to recognize in California our secret sauce. We have a big comparative advantage in the integrated medical groups we have in the state as they develop the contracts with the health plans in the state. These are the big 4. Kaiser Permanente, as you know, has 40% of the commercial market, but Blue Shield at 800, Anthem Blue Cross, United, together that's about 1,100 right there. Okay, so also what we know about these is about 200 of these medical groups have for years, since 2003, I think, been a part of the Integrated Healthcare Association Pay for Performance, which gave them the experience to be able to compete in increasingly total capitated or full risk contracts. And you see the evidence of that in the data that Dolores has just shared with us. 41% of California's physicians are already in medical groups, and over time in the last few years, more of them have gone from being independent solos to being affiliated in some way. We have the foundation model in California because hospitals can't really own medical groups, but that relationship has increased over time. It's interesting, data that we've developed at Berkeley, there's no question, and Emilio will elaborate on this, that consolidation raises prices. But one of the things we found that's largely true if the consolidation is around physicians who see advantages actually to becoming a part of a hospital or health system in markets that aren't already consolidated. There's no evidence there of raising the prices, and that's kind of the future, perhaps, where we need to go. It's different when you're looking at markets that are already consolidated and then grow even more. So right here are some of the key features of integrated care. In the interest of time, I'm just going to hit the first 3. You have these slides available, happy to answer questions. The ability to really know your patients, stratify by degree of illness, stratify by behavioral health, comorbid conditions, stratify even further by those with the frail elderly who also have mental health, so you can really target your resources. Very proactive team-based care, big emphasis prevention and screening, and then a lot of the transitions that can occur and need to occur. In the interest of time, I won't go over the others. So here's some very interesting data shared pretty much for the first time. A national database that we have based on work we've been doing with the Dartmouth Institute. We're one of 3 centers of excellence in the United States on trying to reform our healthcare system in terms of performance. And we have scales on each of these areas here of what's actually done to patients. As you see here, I'm able to compare the over 200 practices in California with the rest of the country. And as you can see, we have more of these capabilities to deliver value-based care. The percentages are not the percentage of practices that do those things. What they are is underneath each of those are 7 or 8 measurement items, highly reliable on behaviors that physicians and their healthcare teams do. And so it's the percent between 0 and 100 in which California groups do those things. As you can see on all of them, they're significantly higher than the rest of the country. And this is what we have the opportunity to build on. And so I'm going to end with challenges. There's some things we can come back to around how might you measure these things, et cetera, perhaps in the Q&A. But there are big challenges. A really great session earlier today on behavioral health and mental health and how we integrate that better. And Daryl Steinberg commented on that as well. Prime example of absolutely unneeded complexity, all these different funding streams and so on. We need to work on that. We need to expand screening for social determinants. Across the United States, on all of the key social determinants, only about 15% of medical groups do all 5 of those as an example. We're a little better in California, not much. We need to make new efficient use of electronic health records, but really the biggest challenge, I think, and my suggestion is, as a glide path, we're going to have universal coverage. How are we going to pay for it? How's that going to come about? Let's move these big health plans, and Kaiser Permanente is already there, towards risk-adjusted total capitation in the contracts with insurers, working through Covered California, that create that incentive at the top to stay within budget. Those are the resources you have to work with. And now you have every incentive to keep your enrollees well. So let me end there. That gives you, by the way, the freedom to innovate and do some of these other things we've talked about.
Stephen, thank you. Anthony, take her away.
So good afternoon. Again, my name is Anthony Wright. I'm the Executive Director of Health Access California. We're the statewide healthcare consumer advocacy coalition working for the goal of quality and affordable healthcare for all. I appreciate the comments of my fellow panelists. We have been working on trying to figure out the issue around healthcare and how do we both expand coverage, but also how do we make it sustainable, and how do we improve the system for consumers? Most people find the system fragmented, complex, confusing, and so there is some hope in some of these elements of what has been talked about as integrated care. Can we try to provide some more coordination, to reduce the complexity and the confusion in our healthcare system from the point of view of a consumer? I think that there is a healthy debate. There have been whole issues and panels at Health Affairs about the issue of integration and consolidation, and whether it actually raises or lowers prices, and what is the actual impact and quality with regard to the data, what is the data that's out there. And I think one of the questions about California is if California has actually is a step or two or three ahead with regard to integrated care, why aren't our costs significantly lower than the rest of the country? Why isn't Kaiser significantly lower than its competitors? And I think one of the issues that we look at when we look at the healthcare system is actually based on some of the work by Professor Shortell and Scheffler and others, which is the issue of consolidation. That often with integration, and whether you're pro or anti-integration, at some level it's like the gravity, it's the fact of life now, it's where the system is going. It does often get correlated with additional consolidation in our healthcare system, and we see that in California we have a particularly consolidated healthcare system, especially here in Northern California, especially with some key hospital groups, but also with some with physician groups, with specialists, et cetera. And some of the data by our friends at UC Berkeley and others show that we have in inpatient care significantly higher inpatient healthcare costs in Northern California than Southern California, highly correlated with the consolidation, and that most of our regions in California are highly consolidated. And so, so then what do we do about it? And I think as a consumer advocacy group, we are looking at how do we actually deal with, if it is a highly consolidated area, how do we deal with that? And in some cases, the question is, can you introduce more competition? Or in some cases, is that not possible? For a lot of healthcare, there is a natural monopoly or monopsony in the consumer's experience. People do not really have the option of saying no in healthcare like they do in other markets, right? You don't have a lot of opportunity to comparison shop when you're on the gurney of an ambulance. There is, in many rural areas, the density and demographics of a certain area only really allow for one major hospital. So then how do you, so if normal market economics isn't going to work in all of those situations, then do you need to rely on some further regulation or oversight to deal with the issue of healthcare costs? So while I think that there could be and can be some advantages to integration, I don't think it will ultimately be our savior here. We also need to have some additional tools in place, including greater oversight. I do think that there is a role to try to monitor consolidation and the trend toward it. There's been a rash of mergers going on. Emilio will talk a little bit about the oversight of the Attorney General in this regard. And we have a whole project at Health Access called Merger Watch when these mergers happen, either between hospitals or between health plans, or even these new diagonal, not horizontal or vertical, but diagonal mergers between like CVS and Aetna or some of these other Express Scripts or other issues. And why should consumers and patients care? Well, number one, it's our money. When these entities merge, it's a sign of excess revenues, and they're using the money that they've charged us to go and buy competitors or to go and expand in another market. And at some level, that should be of concern to us. That's money that could have gone to reduce premiums, invest in quality and equity. I think there is this sort of traditional antitrust analysis of, does this reduce choice? Does this reduce competition? And I think we're also interested in using that as an opportunity to take a look at corporate behavior. If there is a bad actor in the healthcare space, we want to make sure that that there is provisions, undertakings to make sure that a company that wants to get bigger also has to get better. So, we think that that there is some additional tools to do those kinds of reviews. We're glad that last year Governor Brown signed a bill that we sponsored, AB 595, to increase Department of Managed Healthcare authority over health plan mergers. But I think that there's also work to do after the fact, such as, for example, the legislation that we worked on last year on anti-competitive practices that Sutter and other hospital chains have been shown to engage in with regard to, you want to contract with one hospital, you have to contract with all, or some of these other types of issues. And even in the situation of sort of that individual mini monopoly that you face when you're in that emergency, on that gurney in the ambulance going to an emergency room and you end up in an out-of-network hospital, there is a bill this year, AB 1611, on surprise medical bills when you are in this situation, and to have some limited oversight over that. I'll just simply say that we do think that this year we do have a range of bills like that hospital bill, as well as others, to try to deal with healthcare costs. But ultimately, we think that if we are going to move toward a more integrated healthcare system, and that tends to be correlated with a greater, even more consolidated healthcare system, then we need to have greater oversight by the state, using its tools either as a regulator or as a purchaser, the purchasing power that it has as Medi-Cal, as Covered California in these broader range. And we can talk about that more in the back and forth. But we think that it's absolutely crucial that we get everybody in the system, and it's absolutely crucial that we make this a better experience, but we have to control costs, and if the market's not going to do it, then we need to have a greater role of public oversight in order to get that done. Thank you.
Awesome. I know I pressed them to be quick with their slides. Emilio, I know you don't have any slides, and
I don't have any slides, so some might say that's a good thing, because in the 21st century it seems to be nothing but slides. So we'll find out whether that's true or not. Hi, I'm Emilio Varanini. I'm with the antitrust section of the California Attorney General's office. It is my distinct pleasure to be able to talk to all of you about these very important issues. The Attorney General, as you've heard in several of the panels throughout the day, is very much committed to health care, as much, or perhaps, and don't report this back to the governor, even more so than the governor on health care, and has a number of measures that he is either sponsoring or a number of actions that he has authorized to try to make the healthcare markets better for all of us, for employers, for patients, for the plans, and yes, even for providers themselves. And so what I'd like to do is have a step back a little bit. I am, by the way, the lead attorney on the Sutter case that we brought, but I won't be talking about that. I'm also the lead attorney for our office on CVS Aetna, but I won't be talking about that either. Both matters are in court. We do our talking in court, so if people are really interested, you can read what we've been filing, because there's been quite a lot. But let me have a step back a bit and talk about what do we mean by consolidation. and what do we mean by integration. Okay, so when we talk about consolidation, we're talking about hospitals buying other hospitals or hospitals affiliating with a physician group. Okay, and yes, we all know there's the bar on the corporate practice of medicine about which my office feels strongly, but we all know that you can get around that with the affiliations. Okay, so we think of that as an acquisition. And so back in the 90s, the thought was maybe this wave of consolidations in healthcare is okay because either there are no bad things that are coming out of it, no increase in prices or lowering in quality, and because back then in the 90s, the name of the game was supposedly integration. But what did integration mean back then, and has that changed today? So back then, I'm sure a number of you recall, integration was a buzzword. It wasn't really clear it meant anything, but insofar as it did, it was like, okay, doctors will talk to hospitals. Later on, okay, they'll put in electronic healthcare records. Great, so then now doctors can look at electronic records, hospitals can look at electronic records, and don't get me wrong, that's a good thing. Ultimately, it became a government mandate under the Affordable Care Act, which tells you it is a good thing. But is that really what we meant by clinical integration? And the facts were that back then, consolidation also happened, and it still happens today because physicians in particular or other providers feel they have no choice. They need to survive, and there's somebody out there with deeper pockets, so that's where they're going. Or maybe the person with the deeper pockets will manage the paperwork for them so they can do less of it. But that's not really what we think of by integration. Nonetheless, things kept humming along, but now here we are, and we know what the results of consolidation are, and they are bad. So we know from Steve Shortell's work and the Petrus Center's work, we know from the cases that both we and our federal counterparts have brought, and in fact, for those who do secretly want a single-payer system but have not wanted to voice that at this conference, I've kind of noticed that people at this conference are not very enamored of a single-payer system, whatever that may mean. There's a very interesting study out of England on what happens in single-payer systems with provider concentration, and the results are all bad. With concentration comes increased prices. With concentration comes lower quality, and that includes single-payer systems. So for those who think that price caps are in a single-payer system are going to solve everything, and I'm not here to debate price caps in a single-payer system, I'll leave that to other people and wiser minds than myself, it's not. So we know that's a problem. So the question is, what do we do? Well, for one thing, and I heard a very interesting panel earlier today, we want to make sure that if there's going to be consolidation, it's because really that's going to lead to some beneficial outcome. We don't want physicians or rural hospitals to feel desperate and feel like they have to be picked up. And so initiatives that we think about to deal with that are very important. And second question, do we need consolidation at all to achieve benefits? So this kind of brings us back to integration. But I want to note before I talk about integration that think about healthcare systems that are out there, and then think about Canopy Health. Okay, so why do I bring up Canopy Health? Well, the chief medical officer for Canopy Health spoke earlier today, so that helps. But Canopy Health is not a system. They all bargain separately with the plans, okay, on a number or wide range of different products. And then they have this offering for which they have a limited Knox-Keene license. It's a HMO product that they work with the plans on. And Canopy Health enables, one could say, a wide degree of integration outside the bounds of a formal system that has been built up through acquisition. Now, that doesn't mean under antitrust law, if you say, okay, we'll have an affiliation rather than an acquisition, you're suddenly okay. A joint venture can still run you into problems, but it also raises the question of why do we need consolidation at all if there really are benefits there. But let's talk about what does integration mean? And so in preparation for today's discussion, I went back and did a little bit of a trip through the past. I went to look at what we and the federal government have said in the past about integration. And you know what I found in the 90s? What they were saying, and then even in the early aughts? Basically the same stuff Steve's saying. So do you think I'm going to agree with Steve? It's all about care coordination? No. To me, care coordination, that justifies anything and everything. Doctor talks to a hospital, boom, care coordination. So we have to think about, what does integration mean? Does it mean something more than that? And what I've noticed is as you get away from the aughts a little bit and you look at what antitrust enforcers are thinking, and you look at what policy people are thinking about integration, and you think about the panels we heard today where everybody all of a sudden started talking about capitation and sort of sharing both the upside and the downside, and how do we do population management, we're beginning to see that actually integration is something that's more sophisticated. And that if you're going to claim integration in whatever setting that we're talking about here, we can come up with something more sophisticated to better separate sheep from goats. So what is that? First of all, we're talking about goals, right? We want to make sure, are there clear goals? Improving the health of a population, quality, okay, reducing cost or cost efficiency, concrete goals, measurable standards for achieving those goals, performance metrics. You know, how do we assess whether these goals are being achieved? Some sort of incentive structure. How do we, where's the incentives for achieving these particular goals? So when we think about all of this, and we think about sort of the optimal clinical integrated arrangement, a capitated model, and a true capitated model, we begin to see the kind of integration that we should be shooting for. And we have the data, thanks to Dolores, to be able to measure. When do we have the kind of organization, the kind of structure that's really achieving these goals? I'm glad to see ACOs are achieving these goals, and I'm glad to see capitated arrangements are meeting these goals. But I don't hear consolidation. I don't hear it has to be under a single ownership structure. And that's very important, because then we don't have to worry as much, although there still is a potential worry about the downside, increased prices, or even lower quality. I want to give one final thought, total cost of care. So we heard something about that from Dolores at the beginning. And total cost of care is interesting. If you think about looking at the costs of a patient, tracking that patient over an episode of care, and comparing patients to each other, it is sort of an innovative way of trying to figure out when does an assertedly integrated arrangement actually deliver benefits, okay? The anti-competitive effects are easy. We go look at price, we're done, or lower quality, we're done. But total cost of care is interesting, but I still think, in spite of the pioneering work that Dolores has done, which I find interesting, there's still more work left to be done. And the reason why I say that is there's a 2018 paper by Einef, if I'm pronouncing his name correctly, on Medicare end of life. And it was originally thought that, oh, if we can show that a system reduces utilization on Medicare end of life, that shows that we're achieving a benefit. But we now know from looking at Einef's work that that's a little premature. People value care differently. So if we think of end of life, there are some people who've made their peace with their family, if they have a religion, with their God, and they're ready to move on. And then there are other people who've definitely not made their peace with anybody and want more time, or others who just want more time, period. And they're going to value getting care, even if that care is, suboptimal. It only gives them, like, let's say, another month. They want that month. They may even want an additional week if they can get it. So we have to, in thinking about total cost of care as a metric and trying to sort of bend the cost curve here, which we all agree is the right goal, we need to be careful that we're valuing total cost of care properly so we can deliver the best outcome for patients.
All right. Raise your hand if you want to ask any of these folks a question, as long as it's really hard and difficult.
One thing, I should just say, I'm not speaking for my office. I'm sorry, I forgot the disclaimer, and I don't want my boss mad at me, so I don't speak for my office, for the section, for any state or federal antitrust enforcer, and any opinions I express are mine alone. I gave the disclaimer. Now I'm good with my boss. Go ahead.
Except for the part where you said your boss cares about healthcare more than the governor does.
Well, he's on record as caring about healthcare, so I'll live with that.
Yeah.
My name is Sarah Wolf. I'm from the University of California, San Francisco with the Person-Centered Reproductive Health Program. And I'm really interested in this panel and this talk right now because of the proposed affiliation between Dignity Health / Catholic Health Initiative and UCSF. And I know that a lot of other people, I know 1,500 people at least have signed a petition, staff, faculty, students from UCSF who are also concerned about this potential new affiliation. Concerns are about patient care and access to reproductive health services for patients in San Francisco, concerns about providers not being able to provide care based on evidence-based care, rather care being based on ethical or religious directives. And I personally am also really concerned about what precedents this sets. If the University of California, San Francisco, a leader in reproductive health, is affiliating at this standard with a Catholic hospital system, and what that means in the future for other universities around the country, and what they will be used to justify in places that have much worse access to reproductive health care services. So my question is, what is the role of the Attorney General's office in regulating this? What news or updates can you give us specifically on this case? And what can people like myself and others that I know who really care about this do to make a case to your office that this is not something that should move forward?
So the Attorney General has the power to review acquisitions and affiliations both through the antitrust laws and through our charitable trust laws. So I don't doubt that this affiliation is being reviewed. I did write down the information so that I could make sure that our office was aware of the affiliation on the off chance that somehow they are not. I personally have not been working on that investigation. I would in fact have no idea at what point we would have an investigation into that, as I've been a little bit busy lately, but I certainly consider the issues to be important. I will make sure my office is aware of your views. You can, if you want, you can contact me. I'm happy to give you my email address, and I'm happy to forward any information you give me to others in my office so that we're aware of the issues that you have raised here today. But I did take notes, and I will make sure they are aware of these issues.
That's a great offer, Emilio. Thank you.
And I'll just underline, I think Emilio answered the question, but I just underline just the importance of the issues you raise. I think this has come up with a number of different hospital mergers and acquisitions and arrangements over the last several years. There have been reviews that the Attorney General has done in reviewing some of these cases. My organization also hosts the California LGBTQ HHS network, where there's a host of issues, not just on reproductive rights, but on LGBTQ culturally competent care that are raised when you're dealing with Catholic healthcare systems. And I do think that there is a role, whether it is those issues or whether it's just keeping the emergency room or other key services open in a certain community or other things, where there is an appropriate role for public oversight to say, is this service going to continue? Is this community still going to be served in the same way that it can and should be? And I think that it's useful when the AG has had public hearings on these issues or other entities. Part of the problem is that the Attorney General's authority is on, as he mentioned, on antitrust and on this issue of charitable assets of nonprofit hospitals. There's not I think that, frankly, the Attorney General needs more authority over the broad range of the transformation of our healthcare system, and that's something that we have worked on in past years in the legislature and will continue to do so.
We're going to make that be the last word. I just am reminded, listening to each of you up here, that we could have done a 2-hour graduate level seminar with each of you on this stuff. You, in fact, probably do those.
They do.
So thank you all for trying to pigeonhole 2 hours into about 10 minutes each. Let's give them all a round of applause, please.